Hi, everyone. This is Tiffany House, and I'm the president of the AMPA. I apologize to everybody that's been waiting. I'm going to give it a few minutes for all the participants to join in. We're experiencing some technical difficulties, and we're still waiting on one speaker to join us, but we are going to go ahead and get started in the interest of time. And so with that, I'm going to go ahead and introduce everybody. So today's webinar is on patient-reported outcomes. And we're very lucky to have two great speakers today. The first one that will be speaking is Maudy Theunissen, and her presentation is going to be on when a hospital and a patient organization work together. Maudy is a physician researcher and PhD candidate at the Center for Lysosomal and Metabolic Diseases at Erasmus University. She focuses on research into the mechanisms that underlie the differences in response to ERT in adults with Pompe. By combining clinical data and patient-reported outcomes, she hopes to improve and personalize treatment. Besides research, she's involved in the care of adults with Pompe disease in the Netherlands. And Maudy was going to be our second speaker, but will be our first speaker. And then I will introduce Dr. Vanderbeek following Maudy's presentation. And following Maudy's presentation, we'll have a short Q&A. Then we'll have Dr. Vanderbeek's presentation and a longer question and answer. If you have any questions, please type them into the chat box or the Q&A box at the bottom of your screen. And with that, I am going to turn it over to Maudy. Maudy, welcome.
Thank you, Tiffany, for introducing me. I'll try if I can share my screen. Do you all see my presentation now?
Yes.
Okay. Yeah, so thank you, Tiffany, for introducing me. So my name is Maudy Theunissen. I work at the Erasmus MC University Medical Center. And today I'm going to talk about some projects that we do together with the IPA. Share screen, yeah. I would like to elaborate a bit on the first project that we work on together, which is the IPA Erasmus MC Pompe Survey. Dr. Van der Beek will later on explain how this began and some first results, but we've switched around to presentations today. So I will focus a little bit on where we stand today and the new design that we made. Also, I will talk about participation in the survey. I will also talk about another survey, which we have set up in collaboration with the IPA as well, also to show how we can use patient-reported outcomes when a question arises from patients themselves. I will mainly focus on the results of the survey, but also we'll talk a little bit on how we got there. First, the Pompe survey. In total, we have over 500 patients that participate or participated in the past in the survey, which is a lot if you consider how rare Pompe disease is. In total, we have over 20,000 questionnaires filled in over time. And the patients in the study come from all over the world, mainly America, Canada, Europe, also Australia. And then we collect all the surveys in the Netherlands in the Erasmus MC. And of course, we hope to include more patients in the future from more countries. At the moment, most of our patients reside in the Netherlands, but also Germany, UK, USA, Canada, Australia, France, but also other countries like Belgium or Spain. And then last year, it was a special year because it was the 20th anniversary of the survey. So we thought that would be a good time to see what we can improve and what needs to be changed to the survey. So that's how we got to the new design of the study. We have renewed the Pompe survey itself, so the questionnaire itself, and we've done that by looking at feedback that participants gave us the last couple of years. Is there a theme, for example, that keeps coming back that needs to be changed? But we've also looked at answers to open questions, and of course, over the last 20 years, there has been new insights into, for example, the course of the disease, but also treatment effect. The goals of the survey now are the same as it was when it started. So we want to gain a better insight into the course and the severity of the disease, but also a better insight into the impact on daily life of patients. And we want to monitor and evaluate the treatment effect. And these goals are the same as it was in 2002, but I think they're still really relevant also with new therapies coming to the market in mind. And then next to renewing the questionnaire itself, we have also designed a new digital environment. This is easier to use than the old digital environment. You can pause this when needed, and then you can just restart it at the moment that suits yourself best. We also created a new patient information leaflet with most up-to-date information. And we have created a new website, which is www.clmz.nl. And soon we will have our own website as well, pompesurvey.com. This will be easier to find, I think, as well when you don't reside in the Netherlands. For now, it is clmz.nl. And if you go to the website, it looks like this. If you hold your mouse still here on Pompe Center, this is what will come up, and then you can click here on Pompe Survey. I don't know if you can see my mouse. If you click on there, you will see the part on the Pompe Survey. And unfortunately, this website is at the moment only available in Dutch, but we have all the text ready for the Pompe Survey in English as well. We are just waiting for our team members to finish the website in English and to make it go live. So we're a little bit depending on them at the moment. And then I would like to talk a little bit about participation in the Pompe survey. What does it mean to participate? First, who can participate? At the moment, you can participate in the Pompe survey if you're diagnosed with late onset Pompe disease. But the goal for the survey is to make it suitable for patients with classic infantile Pompe disease as well in the near future. You need to be over 16 years of age in the current Pompe survey. And you need to have a good understanding of one of the languages in which the questionnaire is available. At the moment, the questionnaire is available in English, Dutch, French, and German, but soon Italian and Spanish will be available as well. What does it mean to participate? First, you need to fill out a baseline questionnaire, which is a first questionnaire. And this questionnaire consists of a first part about Pompe specific questions on medical history, but also on family history, and then on current physical condition. And then it's followed by a number of standardized questionnaires, for example, on fatigue, quality of life, daily life activities. And then every year you will receive a follow-up questionnaire. This one will be shorter than the baseline questionnaire because you don't need to fill in information again about medical history and family history. And for the survey, online participation is encouraged. In the past, it was possible to participate on paper as well, but we're trying to encourage everyone as much as possible to go to the online survey. I think an important question, how long does it take to fill in the questionnaire? The baseline questionnaire will take you approximately 60 minutes, and the follow-up questionnaire, I estimate approximately 45 minutes. And this will then only be once a year. If you feel like you want to participate in the new survey, best you can do is contact your national representative from the IPA or the Erasmus MC. Every country has a different national representative. And I think we can make a list of contacts and make this available to everyone, so everyone knows who they can contact. In conclusion, yeah, we have learned a lot from the Pompe survey over the past 20 years. Dr. van der Beek will show a few examples after my presentation. And these surveys or these results we could all not have gotten without input from patients directly, without participation of so many patients early. But I would also like to take this opportunity to elaborate a bit more on a more recent example of how we have used patient-reported outcomes and how this is important. Because the IPA board had indicated that they have seen that there was a big impact of COVID-19 on patients with Pompe disease. And they have expressed that it was important to learn more about this. Was this impact common in patients with Pompe disease? Are there other patients that deal with the same things as some of the patients they knew did? How do patients deal with the pandemic? Did other patients also face challenges in treatment, for example? These are just a few examples of important questions that arise and that can only be answered with patient-reported outcomes, so information directly from patients themselves. So together with IPA, we have set up another survey, the COVID-19 questionnaire survey. And I think always when you start a new study, it's good to check what is already known about the subject. I've tried to come up with 3 main points. The first being patients with neuromuscular disorders, NMDs, were thought to be more prone to a more severe disease course of COVID-19. And in the studies that have assessed this, no patients with Pompe disease or very few patients with Pompe disease were included. But even though we didn't know much about the direct effect on Pompe disease, patients were advised to take additional preventive measures, for example, because there was cardiac involvement, pulmonary involvement, or maybe they used immunomodulatory medication. And because of this potential vulnerability of this group, they're advised to take additional preventive measures. Think of wearing a face mask, work from home, in some cases, maybe even self-isolation. And then third, we knew that in patients with NMDs, again, very little known about Pompe disease specifically, the COVID-19 pandemic resulted in worsening of quality of life, worsening of their underlying disorders, sometimes fear and anxiety, but also challenges in disease-specific treatment. And that treatment can be, for example, enzyme replacement therapy, but also physiotherapy or respiratory therapy. And then we knew that research assessing the impact of COVID-19 specifically on patients with Pompe disease was very limited, and the mental and physical effects in these patients remained very unclear. So the goal from our study was to assess the patient experience of the mental and physical effects of the COVID-19 infections, the pandemic, and associated control measures, specifically in patients with Pompe disease. And again, this was important because the IPA themselves had noticed as well that this was an important question that had arisen amongst patients. So what did we do? We collaborated, of course, with IPA, but also with the national Pompe organizations. We've included patients with Pompe disease over 16 years of age. The questionnaire was available between the 20th of September and the 7th of November 2022. And this was a one-time online questionnaire available in several languages. And then the questionnaire consisted of 3 parts. The first part being patients' overall health with regards to Pompe disease. Second, the COVID-19 specific outcome measures. And then you can think about questions regarding vaccination status, precautions taken, but also COVID-19 infections. And then third, the effect of COVID-19 pandemic, for example, on lifestyle, health, treatment, or mental status. And then if we look a bit further into the timing of the study, This graph first shows the number of COVID cases over time in several countries. And then you can see with the blue bar, that's when the survey was available. So we see that's fairly late in the pandemic when there was not a peak of cases, for example. So that's when we've done the study. I would like to thank our team at Erasmus MC, of course, all the board members and other associates and translators of the IPA, of course, all the patients who have participated. And then if you have any questions, please don't hesitate to contact me, and that can be done through pompe.survey@erasmusmc.nl. Thank you for your attention. Let me know if you have any questions.
Thank you very much, Maudy. I think it was a fantastic presentation. If anybody has any questions, please, you can add them to the Q&A box at this time, or we can answer them after Dr. Vanderbeek's presentation. So you can also put them in the chat box. And I'm not seeing any questions at this time. So I'm going to go ahead and let's move over to Dr. Vanderbeek. Dr. Vanderbeek is an assistant professor and consulting neurologist at the Department of Neurology, Center for Lysosomal and Metabolic Diseases at Erasmus University Medical Center. As a neurologist, she's involved mainly in the care of children and adults with neuromuscular diseases. Her current scientific work focuses on the long-term effects of enzyme replacement therapy in children and adults with Pompe disease and the development and validation of new outcome measures. She's an active member of the European Pompe Consortium, leading the work package on patient-reported outcomes, and has participated in several industry advisory boards. Furthermore, she is a co-chair of the Muscle Working Group of the European Reference Network for Neuromuscular Diseases. And with that, I'm going to turn it over to Dr. Nadine Vanderbeek to discuss the value of patient-reported outcomes, the patient's voice. Thank you, Dr. Vanderbeek.
Well, thank you, Tiffany, for this kind introduction. Sorry, I was late for this webinar, but my computer crashed completely, so I hope it works well now. So I will try to share my presentation. So hopefully you can see it now, I think.
Yes.
Yeah, so it seems to work. Okay, so a little bit about me. You already heard that I work at the Erasmus MC University Medical Center, which is the single center for Pompe disease in the Netherlands. And so patients from all over the country come to our center for their diagnosis or their treatment of disease. And in 2013, I've received my thesis on Pompe disease, and it was on the clinical effects and the disease course and the results of enzyme replacement therapy. So I'm already involved for some while. But today I'm going to talk about the voice of the patient, so your voice. And it's really important because we really learn a lot from patient-reported outcomes. And I will give a bit of a background. I hope it's not too scientific, but I'll try to explain to you what it means to us as a physician and take you through it along the way. So the question that we as physicians are getting is from the patients is, well, if you have another treatment, how will it make me feel, and how have others like me felt? And what's important and why patient-reported outcomes are important is because actually the patient's voice can be best captured via patient-reported outcome measures, and it's always relevant. And I think it should be assessed in all clinical trials. But what are patient-reported outcome measures? And actually, it's anything that comes directly from the patients without the interpretation of someone else. That was an interruption of my Siri on my phone. Sorry. And patient-reported outcomes may refer to disease symptoms or side effects, and pain, fatigue, or anxiety, but also some functional outcomes, but also very relevant constructs such as health-related quality of life, which is difficult to capture in any other way. And patient-reported outcome measures, if we're talking about these PROs, as we call them in short, it's not the same as just asking questions to the patients, but they concern validated questions in a question list. And you heard me say already that I think it should be used in any clinical trial, but to date, I think less than 50% of the approved drugs have included patient-reported outcome endpoints within their trials. And nowadays, it's very considered late in the process of constructing of a trial. And I think this should be done much earlier. And what do they add? Well, so to the physician, they give a much better picture of the benefits of the treatment and a better understanding of the patient's experience. But as a physician, you can also try to improve your future clinical trial methods. But they also add to the patient themselves, because they can see, well, how does my experience align with my expectations or expectations from others? And are there still any unmet needs that need some further improvement? And I will focus a little bit more on the patient-reported outcome measures that have been used in Pompe's disease. And it's always a question, which one should you use? Because at the beginning, there were no specific patient-reported outcomes for Pompe disease. So we use some generic outcome measures, such as the SF-36, which is a measure of quality of life, and the fatigue severity scale, and also some other global scales. But you could imagine that for measuring activities or participation in daily living, you would prefer to have a more disease-specific outcome measure, which did not exist in the beginning. So I will start first with the generic questions, and that's actually where the collaboration between the IPA and the Erasmus MC started. 20 years ago, you already heard from Maudy. It's an anniversary actually this year. And it started when there was a need for information on the disease symptoms, on the course of the disease, and we needed more information on the impact on the daily life. And at the moment, you already heard, we have more than 550 unique patients and a lot of questionnaires that were already filled in by all of you. And I think it has brought us really much more insight. And maybe some of you know from the earlier days, you can see here Marloes Hagemans. And she was followed on by Denise Gungur and Chris van der Meijden. And here in the last slide, you see Maudy, who you can also see in real life right now. And we learned a lot. And first of all, we learned a lot about the disease itself. So when do the first symptoms start? When do patients start to use a wheelchair? What are their first symptoms? And we also saw that there was a delay between the first symptoms and the diagnosis of the disease of about 7 years, which is quite a lot. Certainly now it's a treatable disease. And we also saw that fatigue was actually one of the most important problems that the patients reported. Over 90% of the patients were fatigued, and we measured it by the fatigue severity scale, in which a score of 4 or more indicates that the patient is fatigued, while healthy controls score around 3. And you can see here in this figure that most of the patients score well above 5. So fatigue is really an important problem. And 65% of the patients indicates that it's one of their most disabling symptoms. And we have now the enzyme replacement therapy for quite some time now. And what we saw when we asked the patients by filling in this fatigue severity questionnaire multiple times, we saw that with enzyme replacement therapy, we saw a decrease in the amount of fatigue that was reported. So, and this is an effect that cannot be captured by any other outcome measure in a physical way. And also, when we look at the health-related quality of life, which is measured by the SF-36, it measures all kinds of different domains. I will not elaborate on that a lot, but what you see here, where the arrow points, is the physical functioning of the patients, which is the most affected, while actually the mental aspects are affected. Which you can see here below the horizontal line, but not as much as the physical domain. So first of all, we didn't know whether it was useful to use any patient-reported outcome measures, the generic ones in Pompe disease, but I think over the years we have learned that they are indeed very useful. So I think the answer is yes, but now what about the disease-specific questionnaires? I think this is a quote that I also used in my thesis, and I think we always think that we can do it better than the existing skills, and we start with quite an optimistic view. I think we will make a better scale, but still, with this in mind, we tried, and I think there are now several disease-specific outcome measures for Pompe disease. 2 scales that were developed by Sanofi, which are the lower 2, the Pompe disease symptom scale and the impact scale, and we developed the RPECT scale in short, and this was in fact developed with all the information that we got from the patients from the Erasmus MC survey. So I will only talk about this second scale. And I want to give you a little bit of a background before I can explain what we did. And normally patients are asked, are you able to drink, for example? And then we ask them, it's impossible, very difficult, difficult or easy. And we just give some ordinal number to it. And then we measure whether there's a change when you give a certain treatment. But it's very likely that an increase of 2 points here from impossible to difficult is not the same step that needs to be taken as from very difficult to easy. In other words, you would actually need an interval scale, such as a thermometer. Here you know for sure that a 2-degree step up or a step down, it's always a 2-degree difference. But many of these other scales do not take this into account, so you get a very skewed outcome. So what we actually did with this RPEC scale is that we transformed this such an ordinal scale to an interval scale. And what you do then is that if you look at these first two questions, are you able to eat or are you able to run? You have a patient who is unable or doing it with difficulty, and he ends up here on the scale, while there's another patient who can do anything without any difficulty, and he ends up here on the better end of the scale. So here you can see there's a real transformation from this scale to an interval. And what you can do with it is that you can measure patients at the lower end and at the upper end of the scale in the same ruler, which is important when you try to say anything about it. So I already said that it was constructed from this IPA survey, and we focused on the most limiting problems. And I will go over this because that's a bit too difficult to understand. And we ended up with 18 questions that appear to be very relevant for the patients, which all had to do with activities in daily living. And with this, we were able to discriminate between groups. So we can discriminate between patients who are still very mildly affected or patients who are very severely affected. And we also showed that with this measure, we could measure changes over time. So that's something that we call responsiveness. And that's something that you want to see when you look at enzyme replacement therapy, for example. But what you want to do when you look at patients is you have some physical outcome measures and you have these patient-reported outcome measures, and ideally they should match, and they should not measure the same, but they should at least align with each other. That when you find an improvement in one, you also want to see an improvement in the other. And it's actually, some of you may notice from the film The Matrix, which you have several levels of reality. So they should be on the same level of reality and not in separate worlds. And what we see here is when we look at this RPACT scale, which is a measure of the patient-reported ability, and we look at the changes in muscle strength, as you can see here in the upper panels by MRC sum score and handheld dynamometry and the distance walked, you can see actually that these graphs look quite similar. So they really reflect the changes in muscle strength and function. And this is a little bit of a small graph, but if you these are actually the results of the recent COMET trial, in which the aval glucosidase alpha was looked at against the older myozyme. And these are the physical outcome measures. And in this trial, we luckily had also several patient-reported outcome measures. And when you look there at the outcome measures, it also looks quite similar. That actually as well the physical outcome measures, but also the patient-reported outcome measures seem to favor the newer product, which is, I think, really nice to see this. But I think we can still do much more with the patient-reported outcomes in the future. So I will just briefly touch upon some opportunities that we may encounter. And one of these things is that we call it a minimally clinically important difference. So actually, what is the smallest difference that is really important for a patient? And if you look at the trials, I depicted here product A and product B. And what we get as a physicians, we see a statistically important difference. But this does not always mean that it's relevant also for the patients. So that's the question that we always have with trials. Is it relevant for the patient it concerns? And what you would actually like to do is, here I have just depicted 10 patients with a random graph. And patients, of course, all react differently to a therapy. And if you just look at these two patients, one improves and one declines on the same treatment. And you would like to use this individual responsiveness to decide, well, maybe this is a patient that needs a higher dose or needs another treatment. So hopefully in the future we can do more with this individual responsiveness, because now trials are mostly reporting only on outcomes at a group level. But I think the individual underlying the responses is yeah, of course, very important. So hopefully this can guide future decisions. And I think also what is acceptable for a patient or what is improvement for a patient may differ between patients, a younger one and an older one. Maybe the older patient thinks, well, I would like just to play chess with my grandson or walk a little bit. But the younger one wants to be active. He wants to do sports. He has his work. So I think the expectations of patients can be really different, not only with age, but also with other subgroups that you can make. And this is some concept that we call patient acceptable symptom state. So when you look at these patients in a trial, what is improvement? I think for the older patient, if there's a little bit of a shift of an improvement, he says, well, I think really this treatment is working. But the younger patient would like a much more improvement before he says, well, this is really doing my benefit. So I think these are some concepts that we need to take into account into the future, and patient-reported outcomes can help with that a lot. So I think as a physician, I think the patient-reported outcomes are truly important and really valuable when we evaluate the patients with a disease. And I think when you're talking about patient-reported outcomes and clinical measures, they are not the same, but they are complementing each other really well. So actually the one cannot do without the other. And I think in the future we could use these patient-reported outcomes also for precision medicine, as we call it, for future treatment decisions, for example. So here again, our team at Erasmus MC, and we also work closely within the European Pompe Consortium, and of course also with the IPA. And for the contact details, you can always contact us. So thank you.
Thank you very much, Dr. Vanderbeek. That was an incredibly interesting presentation. And really, I think you really made a really great case for the importance of patient-reported outcomes. I think I'm going to take things off with a question I have myself. Dr. Vanderbeek, what do you think is the most important finding that's come out of patient-reported outcomes for Pompe? I know you mentioned pain and fatigue, but in your experience, what do you think has been the most important thing we've learned?
Yeah, I think the most important thing we've learned is that we as physicians have so many ideas about what we can see from a patient or what it's like that we see in the room as a physician. But I think what the survey has learned us is that patients maybe that for us it's important if patients are in a wheelchair or on a ventilation, but for the patients it may be more important that they are fatigued and there is nothing they can do about it, or they have other complaints that do not always align with what we think that's important for the patients. So I think the most we have learned is that that we should actually listen better to you, and that we need outcome measures that that are really important for you, that that can measure really what's going on in your daily life.
Yeah, I think that's a good point, the listening and I think more sensitive outcome measures, which in my opinion, the patient-reported outcomes tend to be more sensitive to our daily life, as you mentioned, versus a 6-minute walk test, or which is going to capture more significant changes, if any. But what happens in day-to-day is, very important. And then there was one question: have you seen any regional variability in the patient-reported outcomes?
And yeah, of course, we have seen very much variability, not only per region, but also actually per patient, also within several countries. So when we look, for instance, when we look at all the patients from the Netherlands, we think it's quite a homogeneous group, but actually also within this group, they are really very different. And I think currently most patients that are participating currently in the survey are from Western countries, so also from the UK, from Canada, from the USA. So I think several high-income countries, and the results from there are actually more or less similar. But I think what we have seen so far is that the differences between patients are larger than the differences between the regions themselves. But currently in the survey, we do not have so many patients from outside Europe or Northern America. So that's something we would like to add, of course, in the future.
And I think that is part of the plan for the next phase, with additional languages being added and translations, correct?
Yeah. Yes.
So there's 2 questions in the Q&A. The first one, what are your thoughts about translating descriptive PROs into more tangibly quantifiable and measurable features? Another way to see this is using PROs for idea generation on how to do new endpoints outcome measures, not just the PRO being the outcome measure itself. So I think what he's asking is, can we use the PROs to create new quantifiable outcome measures other than, again, like the 6-minute walk, the FEC, etc.?
Yeah, I think that's one thing that we did with the development of this RPECT scale. That at first, when this IPI Erasmus MC survey started, we asked all the patients for their most limiting problems and how they affected their life, and from there on, we constructed this new patient-reported outcome measure. Which actually is able to measure the activities in daily life. And I think also with other input from the patients, and maybe also with all the wearables we have now, we have all the we all have a digital phone. So I think there may be much more outcome measures in the future, also maybe development of apps that can measure how the patient is doing on a daily basis, instead of only every 3 months or every 6 months or every year coming to the hospital for doing any other test. So yes, I think there are still great opportunities that we can look into in the future.
Thank you. And another question and I think this would really be for both of you. Does the survey take the different mutations into effect? It seems that mutations need to be studied more when it comes to outcomes.
You can say something about it, Maudy.
At the moment, in the current survey, we do not ask about the different mutations. We do keep this in mind with more clinical research, but with patient-reported outcomes, you cannot objectify this. So I think it's always something a bit more difficult. But at the moment, this is not in the current survey.
Yeah, and I think also when we develop the survey, I think it might also not always be known to patients which type of mutations they have. But also that's some wish of us in the future that we can connect somewhere between the patient-reported outcomes, so the survey measures, and the physical outcome measures. And that we, because I agree that that mutations may really play a role in the difference in the outcomes.
Is that being done at all at this point, where the patient-reported outcomes are connected to the clinical measures? Or is that still something that's a next step across the board?
Yeah, I think that's a great wish that we have, but it's still a next step. So I think first the launch of the new survey, I think that's what we're aiming for to do in the near future. And then as a next step, we will try to unite also all the physicians to get together on this, because I think it's a really important step we need to make.
Okay. Another question was, thank you for the very insightful presentation. Moving to precision medicine is really important. Will the survey PROs include the juvenile population, 12 to 16, in the future?
I think this is something that we would really like to develop as well. I think it's really important to include also juvenile patients, but also the classic infantile Pompe patients. So we've designed the new survey now first as the survey as it was, so adult patients with late onset Pompe disease. But we will definitely start working on adjusting the survey a little bit so it's suited for classic infantile onset patients as well, and also make it suitable for the juvenile population as well. I think that would be really good to start working on that as well.
Yeah, and if I may add to that, I think that the general questions in the survey are already being filled in also by younger patients. But it's mainly the standardized questionnaires that they have not yet been validated in the younger population. So also the RPEC that we developed is validated from the age of 16. And I think it would be really good to look into this younger population. But there will probably need to be some adaptations made to the scale, because some of the items that are asked as questions there in the scale are not fully fit to the younger population. So, but that's really indeed something that's worth of interest. Yeah.
To follow up to that, one of the questions just posed is, what is the process of validating a survey? What does it take to get it validated?
Yeah, I think that's actually a really difficult task, because you cannot validate all the items in a survey. Some are just questions asking how patients are doing or what kind of symptoms they are. And it takes really a lot of effort to construct a new outcome measure that's validated. And I think when I look at this this RPACT scale, I think we first published on this scale in 2013, and we're now still in the process of this large-scale validation to making it fit for other countries. So that's a really elaborate, enormous project actually. But there may still be in the information that we already have from the survey items that we could construct to a new outcome measure. But I think it would be best to work now with the existing outcome measures and try change them so that we include, for example, indeed the younger patients that we just discussed. But it's a really elaborate process actually to develop an outcome measure.
Thank you. And Dr. Vanderbeek, you mentioned that less than half of approved treatments had patient-reported outcomes included in their trials. Do you see that trend changing? And why do you think there's reluctance to use them? Is it coming from regulators or from industry or from somebody else?
Yeah, I think there's a trend that this changes, and it's actually now within the regulation process that it's demanded, in fact, that you take some patient-reported outcome measures into account in your trial, and also what we now see is that that the industry also knows now that it's really important to also capture the voice of the patients within their trials. So I think it's both ways, but it's also regulatory that new trials should also involve some patient-reported outcome measures. And I think in the discussions with the regulators, there are now also oftentimes also patients involved in these discussions. So I think it's changing for the better.
Good. Maudy, thank you for sharing some of the first findings from the COVID survey. It's interesting to see how the pandemic affected our community. One question that came up, based on the results, what was the most surprising thing that you learned?
I think there's a few things that came up. What I think is interesting is that just under half of patients had an infection, and most patients say, I've recovered within 4 weeks, but then it's still, even though they've recovered quite fast, it's still, in my opinion, quite a lot of patients say, I have residual complaints, or it worsened my condition, my Pompe condition. So I think to say most patients recover fast is too short-sighted. We should also look at the other patients that say, I still have complaints from COVID or worsened because of COVID. I also think what's really interesting is that most patients who had a COVID-19 infection or hospitalized was later on during the pandemic. So that does make me wonder were Pompe patients then so cautious, for example, at the beginning of the pandemic, that they caught COVID quite late. I think that's really something that stood out to me looking at the results. And I think it's also always good to realize that half of patients report to be mentally affected. I think that's like a lot of patients. So I think it's good to take that into mind as well within the healthcare of patients. So I think those are the things that stood out to me the most looking at the results.
Thank you. Are there any other questions that are from the audience? I know we've gone over a little bit in time, but since we had a late start, we wanted to make sure we got everybody's questions in. Okay, so there's one more question. Is there an idea to consider the patient-reported outcomes as normalizing variables for other metrics, or vice versa, where other metrics variables can be used to normalize variability within patient-reported outcomes?
I don't know whether I understand the question completely. But what we have looked into now is how they are related. So the physical outcome measures with the patient-reported outcome measures. So, for example, when we look at an improvement in muscle strength of, let's say, 10%, how much improvement do you then see in these patient-reported outcome measures? Can you also give that into a percentage? And so we have looked into now how they are related and how they also are staying connected over time, because what we know now from the results of the long-term enzyme replacement therapy is that many patients experience a benefit in the beginning, but later on they still have some deterioration despite of the treatment. And that's something that we're also looking into. Do we see that only in the muscle strength or in the lung function, or is it also reflected within these patient-reported outcome measures? And it seems that these are quite well connected. So in this regard, I think you can say, I don't know whether normalize is the best word, but you really see that they are connected and they're working in the same direction.
That's really interesting. Yeah, I think it's, oh, he responded back. Thank you for the helpful answer, especially since you couldn't quite understand the question, but it was a very good answer, he said. But no, I think that the fact that they do track is definitely an important tool that we're learning, and an important factor, which would also help to validate patient-reported outcomes, I would assume.
Yes, for sure.
Maudy, you mentioned that a new website would be coming out soon in English on the survey. Will that be announced when it's live?
Yes, we can. We're a bit depending on our colleagues within our center at the moment. But as soon as it's live, we can, of course, communicate it with the IPA and the national representatives, so that everyone can communicate again on their own socials as well. We'll definitely try to make it known if it's actually live.
Thank you. And if there are no further questions, no further last-minute burning thoughts, I want to thank both Dr. Vanderbeek and Maudy Theunissen, and these were both very incredibly insightful and informative presentations. And on behalf of the AMDA, I want to thank you. And I want to thank the community for participating. If you have any further questions, please feel free to reach out to the AMDA at info@amda-pompe.org, and we will present them on to Dr. Vanderbeek and Maudy. And with that, I want to say thank you, and this concludes today's webinar. Thank you very much for attending.